Dr. David Johnson, professor of medicine and chief of gastroenterology at Eastern Virginia Medical School in Norfolk, Virginia. And I'm just back from the American College of Gastroenterology annual meeting held this year in Charlotte, fantastic city, and kudos to the ACG staff for doing a phenomenal job. Again, a hybrid meeting. I think those that were present in person would share and agree the infectious enthusiasm that goes with being back in presence of our colleagues and seeing people that we haven't for many years outside of Zoom calls, and connecting again and listening to the best cutting edge science just is incredible. Let me give you the highlights that I found that were most provocative for some of these presentations. First, a study that was a multi-center study by Brian Fagan and his colleagues looking at upadacitinib. This is a Janus kinase inhibitor for patients that were now being studied for ulcerative colitis. This is presently approved for use in rheumatoid arthritis and psoriatic arthritis, but investigated in multiple other applications. In this case, it's a post hoc analysis looking out at 52 weeks and a dose ranging and difference of 30 milligrams daily versus 15 milligrams. It basically showed significant improvement for the 30 milligram dose, but the clinical remission extension was about a month over the 15 milligram dose. We're still not quite there yet as far as showing as well as I would expect for these agents being really in provocative way. They extended the clinical disease remission, but necessarily I'm not sure that we're quite there yet, but nonetheless, read the abstract. It is some benefit. The second was a virtual reality of application of functional dyspepsia, moving into this whole concept of cognitive behavioral therapy. It's been very effective in a variety of disease states, perhaps in particular more recent with irritable bowel. Group at Mayo looked at this in a double-blind study and controlled study and randomization with a virtual reality headset, 3 different programs they could listen to versus a control group, and they found significant improvements in the dyspepsia scores and quality of life scores. Again, take-home message here, stay tuned. Cognitive behavioral therapy, I think, will emerge more in our functional disease armamentarium going forward. Next was a presentation by Dr. Joe Henderson and his colleagues looking at the high-quality index of colonoscopy, predicting risk reduction for advanced outcomes at 10 years for patients that had no adenomas or serrated polyps on their index exam, and 14,000 colonoscopies in the New Hampshire colonoscopy registry. They found that for high quality exams, that is with an adenoma detection rate of 25 or greater, the index exam outcome was related to a 4% prevalence or incidence of the advanced outcomes versus a 6.7% if you had a low quality exam. I think it will really be helpful if the investigators look at more standard current day values of 40% for high level adenoma detection and really pushing the quality issue. I think we'll see sustained benefit here. So take home message, quality matters. Next was as it relates to colon cancer and younger onset. The group at the Cleveland Clinic, Dr. Carol Burke and her colleagues had looked at this for quite some time, noting that 1 in 5 younger onset colon cancers have pathogenic germline variants, regardless of their family history. In the Cleveland Clinic, less than two-thirds were actually being referred for genetic counseling and testing. And they were making the comment that, in particular in this study, we need to do a better job. Colorectal cancer before age 50, guidelines suggest that all these patients should be referred for a germline pathogenic variant evaluation. And this is something that is not standardly done, even in a center of excellence like the Cleveland Clinic. And the take-home message here is suggesting that health systems should consider implementing pathways to mitigate the potential impact of under-referral. The next was a series, 2 presentations by Dr. Evan Dillon looking at dupilumab, and this is something that has been approved now for EOE, eosinophilic esophagitis, recognizing this is a fully human monoclonal antibody that blocks the shared receptor component for interleukin 4 and 13, which are the key and central drivers for type 2 inflammation with EOE. They presented 24 and 52-week data on the safety. Again, bottom line here was it was efficacious and sustained, giving as a once-weekly dosing. The take-home here is important to recognize these are all PPI non-responders. The majority also had been on a variety of things, including steroids. And we're not sure yet what to do with the milder disease, so recognizing these are patients that typically have more severe disease. Whether or not this newer agent needs to be used in the mild disease remains to be seen. Take-home message, more to follow. Next was a study by Dr. Ronnie Foss and looking at a multi-center on the use of vonoprazan. This is a potassium competitive acid blocker. It's approved in the U.S. for H. pylori, not yet for reflux disease, but this is an expanded phase 2 trial, double-blind, looking at patients with non-erosive reflux disease that received the vonoprazan and then were randomized to receive 10, 20, or 40 milligrams on demand as they needed versus placebo. And they did show that there was a significant effect when patients were now taking it just on demand. If they took it on demand, the sustained resolution was the endpoint. They could not take anything or have heartburn within 24 hours within taking the medication. They were looked at within 3 hours of the ingestion of the medicine, found it highly effective, in particular on demand. So looking at rapid onset within 3 hours, about 70% of patients over on the 40 milligram dose achieve this, something that we can start to look at perhaps in patients who don't want to take medications daily. More to see is how it relates to the frequency and ongoing use. But the take-home message, interesting information, on-demand may be back as it relates to acid suppressant. Next was a study, in particular, another type of inflammatory bowel medication. This was using intravenous risankizumab, which is an anti-P19 interleukin 23 inhibitor, which had been shown superior to placebo. Dr. Marla Dubinsky presented the patient data as it relates to follow-up at week 52 and looking at clinical and endoscopic improvements. The data was good. The endoscopic clinical remission, 23% and 34%, depending on the dose of the risankizumab, and this is given induction by infusion and then by subcutaneous dosing. Subsequently, the data was for clinical remission and endoscopic response, 23 and 36% as it relates to the 2 doses. So again, we're not looking at the best of the best, but we're seeing at least response in a class of therapy that may warrant further evaluation. Take-home message, stay tuned. Next was a ongoing evaluation from the Piano Registry. Dr. Umna Madhavedian and her wonderful registry here has done great for looking at maternal and neonatal outcomes. Piano Registry is the pregnancy and inflammatory bowel disease and neonatal outcomes. In this circumstance, they looked at vedolizumab and ustekinumab, where the data was really not available or conflicting. They found no increase in pregnancy or infant-related complications with either of these compared to no exposure anti-TNFs, thiopurines, or the combination of TNFs and thiopurines. Interestingly, ustekinumab was associated with a lower rate of preterm birth and C-section, so there was no signal, and the take-home message continues of these medications seem safe in pregnancy. Next was an interesting study that was done from the University of Chicago and MD Anderson. This is looking at rituximab, which we know is a monoclonal antibody therapy directed at CD20 positive B lymphocytes, increasingly used in both malignant and autoimmune conditions. Consequence, however, is it may result in hypogammaglobulinemia due to B-cell depletion, and this may result in GI side effects. The authors looked in a retrospective fashion over a 13-year interval and found 10 patients with enteropathy. These were mostly lymphoma patients. That's the most common indication for rituximab. They found that 70% had pathologic diagnosis consistent with common variable immune deficiency enteropathy. All of them received IVIG therapy. Only 2 had symptomatic improvement, however, and others received prednisone, budesonide, infliximab, and vedolizumab, none of which led to clinical improvement, and ultimately 60% required long-term parenteral nutrition. So again, take-home message, be aware of this rituximab-associated enteropathy, and certainly be aware that it's not necessarily responsive to a standard type of inflammatory bowel type therapies, and these patients may require long-term parenteral nutrition. There were 2 studies as it relates to C. diff. One was a RBX 2660. This is an enema that was using an open label type approach, but an investigational microbiome-based live biotherapeutic for C. diff. The bottom line here, risk reduction for recurrence was sustained remission and was 75%. If you took them out to those patients that responded out to 6 months, it was 84% remained CDI recurrence free. And a similar study called the ECOSPOR, this is a study with oral therapy, and this is looking at that processed firmicutes spores, and this is delivered by 4 capsules 3 times over 3 days. They received an induction with a bottle of magnesium citrate. Basically showed the same type of effectiveness here in administering these patients in a double-blind placebo-controlled trial. 79% of these patients were free of C. diff recurrence at 24 weeks. And if you, in the open label trial, this number was 86%. So benefit in both of these, and certainly relievingly to those that provide care for C. diff, and recognizing the implication of getting some of the biomic transfer product. This is something that we may be using in the short term as soon as these things are approved by the FDA. The final one was bile salt sequestrants and microscopic colitis. Very interesting. Dr. Daryl Pardeen's group at the Mayo Clinic, they looked at patients with microscopic colitis. They identified 282 that were treated with bile salt sequestrants, recognizing that virtually all of them had been treated with another medication prior to this, with loperamide, budesonide, bismuth, or mesalamine. And again, these patients received bile salt sequestrants, most commonly cholestyramine, 65%. But again, looking at this, there was a significant improvement, and they looked at complete response, nearly 50%, partial response, 25%. And these are patients that were, a third of those patients that had complete or partial response were still taking a concomitant medication, but the majority of patients improved. Not all patients had bile acid testing beforehand, which I thought was interesting. And there was no dosing effect as it relates to the bile salt sequestrant, meaning you go to higher dosing, it had more efficacy. And they, of course, varied across this, accounting for people that had diarrhea severity or post-cholecystectomy prior to the institution, but none of those seemed to matter. So take-home message here, think about bile salt sequestrants. You have to remember the adsorptive potential of bile salt sequestrants. Certainly potentially risk reduction far easier, and potentially long-term less as it relates to ongoing steroid exposure, something that I find actionable even now. I'm Dr. David Johnson. Hopefully these provide some value to you, and I encourage you to link to the program site, and I'll give you the link in this correspondence, and you can read these abstracts in full where you need more information. Thanks again for listening. We'll see you next time.